Thank you for your kind introduction. Okay, so this is my disclosure. And actually I have another disclosure. I'm an adult neurologist, so I actually don't know why I was invited. But I do see a lot of pediatric muscular dystrophy patients, muscle disease patients, because I'm specialized in muscle disease. So my talk is like, how to approach, but the standpoint from the viewpoint of adult neurologists. Okay, so the major difference between adults and children in terms of evaluating muscle strength is that in adults, we usually perform manual muscle testing, right? And using the MRC score from 0 to 5. But the problem is in kids, of course, at certain age, of course, you can ask them to cooperate and you can evaluate, manual muscle testing, muscle strength. But oftentimes they don't, follow your commands and they will just running around. It's very, very difficult. So you have to observe their behavior and actions. So abnormality in action, observation of abnormality in action is very important and useful even in adults. For example, standing maneuver, I will show you video in the next few minutes, but this is also important. And once they, in the developmental stage, once they start can become able to stand up, maybe you should check whether they can stand up, stand on one foot or even jump, or whether you can check whether they can hop on one foot. And also, of course, in even younger children, of course, you have to check milestones, especially motor milestones for muscle diseases. So adult neurologists usually don't care much about milestones, but this is very important, especially for young kids. Okay, so I'd like to show this video. I guess some of you have ever seen this one. Of course, you know the name of this sign, right? This is like a medical student level knowledge. Of course, this is Gower's sign. But my real question is to you is, which muscle is affected when he shows this maneuver? Okay? So to understand the mechanism, well, actually, when he stands up from squatting position to really standing up, he has to extend 3 joints, ankle joints, knee joints, and hip joints. So let's focus on 2 major joints, hip joints and knee joints. To extend knee joints, of course, you need to use quadriceps muscle. Major hip extensors are gluteus maximus muscle. So those 2 muscles, okay? Then I actually analyzed this video frame by frame manually, okay? So he took actually from this position to finally standing up, he took 2.7 seconds, okay? And very interestingly, from this posture, even just after 0.1 second, he already extended his knee, right? So it means that for all of the remaining time, what he was doing is he extended his hip joint. So it means that clearly he took a long time to extend his hip joint, meaning that at least at this stage, he has difficulty extending hip joint. And this maneuver indicates the difficulty extending hip joint. Okay, I will show exactly the same video again, and it will look different, okay? He already extended his knee joints, and it took a long time to extend his hip joints, right? So once you understood the mechanism, you understand the mechanism, this action looks very different. So this type of analysis, so just saying Gower is positive is not enough. You should really carefully analyze and evaluate the patient's action. And also nowadays, the importance of muscle imaging analysis is, increasing recognized. So this is, unfortunately, we don't have a muscle MRI of this particular patient, but this is the MRI from other Duchenne muscular dystrophy patients. But clearly, see, gluteal maximus muscle is markedly infiltrated by fat. At T1 weighted image, fat is white in color, as you can see by the white color at the subcutaneous fat. So the gluteus maximus muscle is really infiltrated by fat. In contrast, quadriceps muscle, of course, a little bit affected, but much better preserved. So this is very much compatible with his maneuver or his action, right? So comparison between muscle imaging data and the observation of the action is very useful, and you can learn a lot from this one. And this slide compares the muscle imaging data or MRI of the early stage, and to the advanced stage. And of course, the gluteus maximus muscles are affected since early, while quadriceps muscles affected later. And of course, in the advanced stage, all muscles are affected. So this is exactly the same patient 4 years later. Okay, now his maneuver is different. He has to extend his knee joints without putting his weight on the knee. Then he took much even longer time to extend his hip joints. So clearly you can tell that with his maneuver, you can tell that quadriceps muscles are already affected. Unfortunately, I don't have MRI, but I have CT at this point. So you can see, his quadriceps muscles are affected. In CT, fat is dark, right? Dark color. So the muscle in the vastus lateralis is really dark in color. So it means that quadriceps muscles are infiltrated by fat. So again, comparison between imaging data and motor action, is very important to understand the condition of your patient. And also you can learn a lot by doing this. So I really strongly recommend we're analyzing the imaging data and also carefully observing your patient. This is also the case for adult patients as well. This is an adult case. Well, nowadays, I think the 18 years is the cutoff. So still maybe pediatric patients. This is a limb-girdle muscular dystrophy, okay, patient. So let's think about which muscles, gluteus muscle or quadriceps, which muscle is more affected? Right? Looks like she doesn't have much problem extending his hip joint, right? But she used hands to extend her knee joint. And interestingly, she can do this maneuver very quickly. Of course, this is a little bit tricky, but when you do this, you also use your back muscle. So not purely hip extensors, but still she can do this very easily. This is another patient with the same disease. This is older, and he already lost his ambulation. So he cannot walk, but still he can do this, right? So clearly in this disease, probably quadriceps muscle is more significantly affected than gluteal muscle, gluteus maximus muscle, right? Then now you want to see MRI and CT, right? This is his muscle CT. Look at his gluteal muscle, right? Of course, you can see a little bit of fat infiltration, but quadriceps muscle is very much atrophic and almost completely infiltrated by fat. This is well preserved, but this is markedly affected. So this is very much, again, compatible with his maneuver action, right? So this is very important. I want to show, yes, so this is dyspharinopathy. So this is, of course, as you know, this is caused by dyspharin gene mutation and also a recessive disease. And historically, there are two phenotypes, Miyoshi myopathy, which is a distal myopathy, originally reported by Professor Miyoshi in Japan. And another one is limb-girdle muscular dystrophy. Now it is called R2. But now, significant number of studies, mainly imaging studies, prove that they are actually the same disease. But the pattern of muscle involvement is exactly the same in both conditions. So now many people hesitate to call Miyoshi or limb-girdle, so probably we should have the single name. Yes. Okay, again, I want to discuss the standing up maneuver. This is another condition. Again, so let's think about it. Which muscle is more affected? Very difficult. So he had to use his hands to extend his knee joints, but probably hip extension was not that difficult. So again, probably quadriceps muscle is more affected. I think that's what you think. So his CT, yes, again, quadriceps muscle is infiltrated by fat, while the gluteus muscle is, of course, a little bit affected, but not completely normal, but much better preserved. So this is again compatible with his maneuver. So this is his MRI. The pattern of fat infiltration is very unique, right? Look at the vasa lateralis. The fat is infiltrated from outside, but the central part is still there. This is like a from outside to inside pattern, or like a stripe shape. This is called thyroid sign or sandwich sign. Yes. Then many people believe that this pattern of abnormality is almost diagnostic of Bethlehem myopathy. And this is a Ullrich congenital muscular dystrophy, which is allelic to Bethlehem myopathy. And you can see exactly the same abnormality here, although fat infiltration is more marked. Another one, and thyroid pattern again. And this thyroid, or they call sandwich, but the pattern, according to the Chinese group, they say that sensitivity is 90% and specificity is 97% to make a diagnosis of collagen 6 related disease, Ullrich or Bethlehem myopathy. So this sign is very useful. Yeah, so this just summarized the collagen 6 related myopathy or muscular dystrophy, whatever you may want to call. So the earlier onset cases are called, at least historically called, Ullrich congenital muscular dystrophy. Interestingly, they show proximal joint contracture, but while distal joints hyperlaxity. And most of the cases have de novo dominant mutations, but like 10-15% of cases have recessive, caused by recessive mutations. Bethlehem myopathy are actually probably by the same mechanism, but by milder mutation. And they will not lose ambulation until age 50 usually, but still they have joint contractures. But anyway, the muscle imaging, the feature of muscle imaging data are very similar. So you can make a diagnosis. And nowadays, at least for hereditary muscle disease, this pattern of muscle involvement is believed to be specific to certain conditions. So if you learn the pattern of muscle involvement, at least you can narrow down the differential diagnosis, and you may even point out the specific diagnosis, just like collagen 6 related myopathy. So, again, muscle imaging is very important nowadays. So in our laboratory, we receive muscle biopsy samples from all over Japan, but now I always tell the physician to send us muscle imaging data as well at the same time. So otherwise, muscle biopsy, is very useful, but can be misleading because you look at only small piece, small area, right? Okay, so again, just saying proximal muscle weakness is not enough at all, because even this is the thigh muscle. I'm sorry, the thigh level. But even in the thigh level, you can see this one is not affected, while this one is very much affected. So not all muscles are uniformly affected, very selective. Yeah. So again, like proximal, just saying proximal muscle weakness is not enough at all. Okay, then I'd like to discuss floppy infant. This is more difficult for adult neurologists, but of course, for pediatricians, very important. Actually, there are several ways to show hypotonia, congenital or infantile hypotonia. The typical one is head lag on traction, and also no head raising on ventral suspension. And often, if you hold the patient like this, the shoulder, they also often show, always show loose shoulder. And the hypotonia, of course, heel 2-year sign or scarf sign, they're all listed as the sign of floppy infant or infantile hypotonia. But you have to be a little bit careful because even with muscle weakness, they show head traction, head lag, and also this type of changes and loose shoulder. And well, it's not really emphasized, but in my experience, loose shoulder is sometimes very useful, even in adult patients. So on manual muscle testing, you may not clearly, pick up the shoulder girdle weakness, but oftentimes, the shoulder, you can pick up loose shoulder. Sometimes patients have significant loose shoulder. And in congenital muscle disease, without loose shoulder, I don't think the patient can have any muscle disease. All muscle disease patients, early onset muscle disease patients have loose shoulder. So when you would see, of course, there are other differential diagnoses, but when you limit the differential diagnosis to neuromuscular disease, of course, you have to consider a possibility of muscle disease, neuromuscular junction disease, or neuropathic condition. For muscle disease, of course, so clinically, something very important you have to look for is facial muscle involvement and high arched palate. And when your patient has congenital myopathy, they often have very narrow, sharp, high arched palate. We specifically call this narrow high arched palate. And of course, laboratory testing, because most of congenital myopathies are historically at least characterized and defined by pathological features, you often need muscle biopsy even in this molecular area. And of course, definitive diagnosis is made by genetic analysis. And again, muscle imaging is also important. For neuromuscular junction disease, well, patients often show ptosis, and the fluctuation is very important. And of course, diagnostic testing is like neuromuscular, evaluation of neuromuscular junction, conduction by repetitive nerve stimulation. But this is often very difficult for infantile patients. You need general anesthesia, but you need to do it to make a diagnosis. Yes, and also single fiber EMG. And of course, if this is a congenital myasthenia gravis, you need to measure anti-acetylcholine receptor antibody. And again, for congenital myasthenic syndrome, you need genetic analysis. And for SMA or other neuropathic conditions, well, for SMA, you should observe fasciculation, and EMG is very important. But for infantile patients, EMG may also be difficult. So I'd like to focus on muscle disease because my subject is muscle disease. So of course, one major differential diagnosis is congenital muscular dystrophy. And one of the most frequent, at least in European countries, are LAMA2 related congenital muscular dystrophy, which used to be called Merosin negative congenital muscular dystrophy, and usually characterized by this type of leukoencephalopathy-like MRI findings. And well, this is called Merosin deficiency because there is a protein called laminin, and there is 3 subunits: alpha, beta, gamma, and the combination of there are different types of laminin, And in muscle, normally, alpha 2, beta 1, gamma 1, this combination, and this is called 211, is expressed. And the major subunit, alpha 2, was historically named merosin. That's why we call merosin negative congenital muscular, even nowadays, actually. But this merosin, the name merosin is already outdated. So this is more precisely, this should be called LAMA2 related muscular dystrophy. And if you do muscle biopsy, of course, you can make a diagnosis by the absence of merosin or laminin alpha 2. And the diagnosis may be easy. Another one very important for us, for Japanese patients, are Fukuyama congenital muscular dystrophy, which is not present in Southeast Asian countries, but do present in China and also Korea. I don't go into the detail, but this is one of the nowadays called alpha-dystroglycanopathy. And if you perform immunohistochemistry using the antibodies against sugar chain part of alpha-dystroglycan, as you can see, the staining signal is all wrong. This one, GT20ADG, is the name of antibody, which recognizes alpha-dystroglycan, but not the sugar chain part, but the protein part. So you can see it is present. It means that alpha-dystroglycan itself is present, but the sugar chain is gone. So this is actually the start of the, analyzing the alpha-dystroglycan story. And now we know that it has very complex alpha, sugar chain, and fukutin and also FKRP. Now it is known to be our ribitol phosphate transferase. So they are all, necessary enzymes to make sugar chains. And there are other causative genes for other alpha-dystroglycanopathy, but all are basically related to make sugar chain in alpha-dystroglycan. Another one, when you see severe marked neck weakness like this, something you need to think about is LMNA or lamin related congenital muscular dystrophy. Usually laminopathy is a little bit late onset or childhood onset, but in rare cases, they show congenital onset or infantile onset, and they show severe neck weakness like this. Another one, muscle, shows very unique pathological changes. In this disease, you see a lot of, enlarged mitochondria at the periphery of muscle fiber. Now this is called megaconial congenital muscular dystrophy, and which is known to be due to CHKB or colon beta gene mutation. And if you want to, if you are interested in this disease, Sophia Chan from Hong Kong, she just wrote a very nice review in Gene Review, so you may want to check this one. What about this one? This is X-linked myotubular myopathy because they are not myotubular myotubes, but it looks like myotubes. That's why this is called X-linked myotubular myopathy. And usually, typically, patients are very, very floppy, and sometimes they need tube feeding or even intubation. So this is caused by myotubular gene and mutation. Okay, this is another example of congenital myopathy. What is this? Of course, this is Nemaline myopathy. In many of Nemaline myopathy patients, they have facial muscle involvement, and in severe cases have really elongated face because of severe facial muscle weakness. And so far, more than 10 causative genes have been identified, and depending on the mutation, sometimes they show very severe phenotype, but others may be adult onset cases. So I want to highlight the importance of narrow high-arched palate. As you can see, this patient has really narrow high-arched palate. This particular patient is not that lady. You can recognize the hair, right? This one was at that time, actually already more than 10 years ago, 15 years ago. So when I gave a lecture in Bangkok, so he was introduced me as a patient with distal myopathy. And according to him, he started having gait disturbance 10 years ago, and he lost ambulation 2 years ago. And I don't have much data at that moment, CK normal, EMG myopathic, and clinical diagnosis was distal myopathy. And yes, his distal legs looks thin, so maybe that's why they call it distal myopathy. But of course, proximal muscle was already affected. That's why he has already lost ambulation. Oops, sorry. And actually, but he had this one. So I immediately thought about congenital myopathy, especially Nemaline myopathy. So they later did muscle biopsy and found Nemaline bodies. So looking for high arch palate would be very useful even in adult patients. This one, another congenital myopathy. You can see a lot of muscle fibers with centrally placed nuclei. So this is called central nuclear myopathy. In central nuclear myopathy, for some reason, significant number of patients have ptosis and ophthalmoplegia like this, like 1/3 of patients. Okay, I don't go into the detail, but this is central nuclear myopathy. And lastly, I'd like to discuss this case. This is, of course, floppy infant, but had enlarged heart, big heart, so cardiomyopathy. So of course, if you see floppy infant with cardiomyopathy, hypertrophic cardiomyopathy, of course, you immediately need to think about Pompe disease. And in fact, he had Pompe disease. And Pompe disease is important because there is enzyme replacement therapy. I don't go into the details. But this is the initial data. In infantile patients, if you don't treat patients, they basically die within 2 years. But none of them died at the initial clinical trial. For example, this one is our own case. At 10 months old, well, she can't raise, the floppy, right? She can raise hand or legs that much. But after treatment, so she was supposed to die because infantile case. Oops. This is at 2 years old. So this is very impressive, right? She was supposed to die, but she can just run, walk and run just as usual kids. So this is very efficacious. But if the treatment is late, started late, this is a 10-year-old boy. Before treatment, he had to use handrail to climb upstairs like this. And he couldn't jump at all, no space between his feet and the floor. But after treatment, he can now walk, climb up without using handrails, but still, of course, waddling gait, right? And he said that he can jump a little bit, right? So efficacy is very much limited. Of course, still, this is efficacious, but limited. And also, you can see that jumping, this type of analysis, observation is very useful. This is the slide given by the former president of the Patient Society for Pompe disease in Japan. They had 2 daughters. The elder daughter had asthma and liver dysfunction, whatever. So she was just followed up. 2 years younger daughter also had a very similar condition. And at the last moment, she developed cardiomyopathy. And they finally thought about Pompe disease, and the diagnosis was made, but it was too late and she died. And of course, the elder daughter has exactly the same condition. So they checked, and finally the diagnosis was made and the treatments had started. But of course, the efficacy was very much limited. She has never walked after that. But something I was really sad about is this one. Actually, at that moment, she was suspected to have muscular dystrophy. Probably CK was elevated, but they didn't do muscle biopsy because many people think that, okay, for muscular dystrophy, maybe, you don't have to do muscle biopsy immediately. Maybe we can do it in the next summer, maybe in the next spring, blah, blah, blah. Then finally postpone, and then finally they didn't do it. But if they did muscle biopsy at that time, I'm 100% sure we could make a diagnosis. And of course, younger daughter, should survive, and also the elder one maybe much better. Another one is this is immune-mediated necrotizing myopathy. This is one subtype of muscular dystrophy. This can, this can look like muscular dystrophy really in congenital condition. And this is mainly an adult, disease, but, there are patients in pediatric range as well. So you shouldn't miss the diagnosis. And many of them look like muscular dystrophy. So when you see patients suspected to have muscular dystrophy, should not delay the diagnosis. So, and if you wonder if you may need muscle biopsy or not, you should do it as soon as possible. Okay, nothing, you will lose nothing doing muscle biopsy earlier. Okay, this is a summary. Observation of actions, very important. Narrow highest palate may be useful. Muscle imaging is very important. And finally, treatable condition is increasing. You should make a diagnosis as early as possible. And this is my collaborators. And we made a video for muscle biopsy and fixation of the samples. And this video is really highly evaluated. So please do use this one. Thank you very much for your attention.